Morning, everyone. My name is Jeff Kanige. I'm the editor of NJBIZ. Welcome to our discussion of health insurance. There's a reason this subject generates so much heat around kitchen tables and legislative chambers and on the campaign trail. Put simply, health insurance can be so expensive that many folks can't live with the cost. By the same token, it's so important that those same folks quite literally can't live without the coverage. It's one of the reasons that the issue has been front and center in the Democratic presidential primary campaign. We have another debate coming up this week. Two candidates are running on proposals that would dramatically rechange completely the way we do this in this country. Others wouldn't go that far, but they would still dramatically change the way Americans get covered. And then there's a litigation. Any day now, the Fifth Circuit could issue an opinion that would overturn the entire Affordable Care Act and undo the most significant reform since Medicare. Many states, including New Jersey, are pressing ahead with their own marketplaces, and it's unclear how those efforts are going to work out. So we have a lot to unpack this morning. And leading our conversation will be my colleague, Anthony Vecchione. Anthony has spent decades covering the healthcare industry, and in the process has developed a deep understanding of the most important sectors: hospitals, drug makers, biotechs, and insurance. And we're glad that he's applying that expertise as the healthcare writer for NJBIZ. Please welcome Anthony Vecchione.
Thank you, Jeff. Good morning. As the healthcare reporter for NJBIZ, I cover a wide range of healthcare topics, from the farm industry to health systems to relevant legislation, and of course, health insurance. I'm excited to be moderating this panel discussion, and I'm looking forward to hearing from our panelists. We are privileged to have Brian Bodner, Vice President of FNA Insurance Services, Kevin Joyce, Vice President, Insurance Networks at Atlantic Health System, and Michael Munoz, Market President, AmeriHealth New Jersey. Let's give them a moment to introduce themselves, and then we'll get into the discussion. Brian, you want to begin?
Sure. Good morning, everybody. Brian Bodner. I've been specializing in employee benefits for 20-plus years, from a product perspective, from a legislative perspective, past president of National Association of Health Underwriters, so I've lobbied both locally and in Washington regarding healthcare initiatives, and I'm happy to be here today.
Good morning. My name is Kevin Joyce. I'm the Vice President of Health Insurance at the Atlantic Health System. I've been with Atlantic a little over, coming up on 3 years. Prior to that, my last role was Chief Operating Officer at QualCare, which was a managed care company in New Jersey, so I have some good insight on the cost of healthcare from both an employer's perspective and now being on the hospital side from a provider's perspective as well.
Good morning. Mike Munoz, Market President for AmeriHealth New Jersey. We're a health insurance company that insures over 300,000 members in the state, predominantly focused in individual, small group, and middle market public entity business. We do both fully insured and self-funded programs, and I'm happy to be here today, so thank you.
Thank you, gentlemen. In a recent Kaiser Family Foundation tracking poll, healthcare leads the list of possible topics Democrats and Democratic-leaning independents want to hear from the 2020 Democratic presidential candidates talk about during the debates. Nearly 9 in 10, 87%, saying it is very important for candidates to talk about healthcare. In a recent Pew Research poll, 69% of the respondents said that healthcare costs should be a top priority for the Trump administration and Congress. And in the CNN poll, healthcare came in fourth when asked what the most important issue was related to the 2020 presidential race. This morning, we're here to talk about health insurance, clearly a major component of healthcare in this country. So let's get things started with this. For Brian and Michael, what are you hearing from employers? What are their main concerns? And for Kevin, what are you hearing from patients and providers when it comes to insurance?
Yeah, I'll jump in. The easy answer is cost, right? From an employer perspective, it's always about the premium cost, not really about the healthcare cost, and that's where the conversation needs to happen and needs to be focused on the true healthcare cost, not always on the premium cost. You look at healthcare reform over the past couple of years, and what that did was reform the distribution channel. It really didn't address healthcare costs. That's the driver. That's where the conversation needs to be focused, and it needs to be had there.
Yeah, I echo the first thing we hear from most of our clients is affordability and being able to continue to offer quality coverage to their employees. From our standpoint, what we've tried to do is really make it as easy as possible for people to be able to understand what their health insurance is all about, because a lot of people are confused with how the system works and the complexity around it, especially now when more and more people are buying what we call HSA or high deductible programs, where they have a lot more financial liability at hand, and understanding the total cost of care has become more and more important to those individuals buying those type of policies.
Yeah, I would just say probably what flows to my desk most is, people not understanding their coverage, what's covered, what's not covered, the authorization process, what's going to be their liability, what the just overall confusion on the products themselves.
Maybe that's a good segue into what are some of the main obstacles facing health insurance in New Jersey? It could be legislation, state or local. What would you say?
Well, I mean, obviously the state's taken a number of steps to stabilize the individual market. The governor and the legislature work towards implementing an individual mandate. They also set up a reinsurance fund to reinsurance claims above the threshold to continue to make it affordable. In the state, I think the biggest challenge I see in the market at this point is really the small group marketplace. It's been decimated over the past few years. At its height, it was about 900,000 members. At this point, it's about 320,000. And we continue to see that deteriorate over time. My biggest concern, obviously, is the rising costs within that segment based on the fact of the risk profile in that segment has changed dramatically. And that can be attributed to a number of things. We obviously saw a number of people move into the individual marketplace. That grew pretty substantially in the state, so you saw a shift in that direction. You have more and more people moving towards employee leasing firms. That accounts for a percentage of it. You have some employers that have decided not to offer coverage in the state. And then last but not least, and most importantly, what we've been pushing for and advocating for is the ability for companies to come into our marketplace, undermine the market by selling policies that don't have to comply with regulations that are set by the Department of Insurance, by the legislature through the mandates that they provide to make sure that people are protected, along with the fact that they have the ability to medically underwrite policies to set rates based on that company's health risk profile. And in our mind, in a marketplace where we've tried to keep consistency and affordability top of mind, that undermines that whole thing. So there's two bills, both in the Senate and the legislature, that we're supporting, where the sale of small group stop-loss policies would not be made available to what we call these level-funded, self-funded programs that are being sold in the state of New Jersey by carriers who, quite frankly, don't even participate in the individual or regulated small group marketplace. So essentially undermining the market that the state and we, participating in that since the implementation of the ACA, are really concerned about. So top of mind for me would be, what do we do moving forward as it relates to stabilizing the small group marketplace?
Yeah, and from the perspective of employers and advisors, it's all about options and having products. So one of the things Mike mentioned was the underlying stop-loss issue. Especially in New Jersey, what we've seen is products being sold where advisors don't really understand the implications of the underlying stop-loss contracts. And employers are really at a disadvantage if you're working with somebody that cannot explain the underlying stop-loss contract. Usually it's not even part of the conversation, quite honestly, and that's very, very dangerous because the products are based upon that, and the claims being paid and being reimbursed are done so via the underlying stop-loss policies in force. So you see it all day long. So just be cautious when you're dealing with those products. From our perspective, it's great to be able to talk about those products because it's an additional option. You have to really be educated and knowledgeable in that area because you can make missteps that are extremely expensive.
In 2020, New Jersey will move to a state-based exchange. What kind of impact do you think this will have on New Jersey residents and the insurance industry?
So for 2020, there's really not going to be any real change from a shopping experience standpoint. What you'll see is the state working towards setting up the exchange for 2021. It'll be fully live. We hope, and we are looking to partner both with the Department of Insurance in the state to make sure that as we've been participating in the individual and small group marketplace through the federal exchange, that we will continue to do so, and really focused on making sure that the appropriate systems are in place to enable us to continue to offer affordable coverage within those vehicles. So our expectation is that the governor and the legislature will follow suit in what they've done in stabilizing the individual market, and that will follow through with the setup of the exchange moving forward. We've seen tremendous growth in that market segment since the implementation of the ACA, and we'd expect that that will continue to happen as long as it's stable, affordable, and it's easy for people to be able to access.
Yeah, it's, the devil's always in the details. So, if you look at New York, over the last couple of years, when they went to the exchange model, everybody was thinking everything's going to be on an exchange. That's how everything's going to be delivered. Really didn't come to fruition that much. So, just like Mike said, short term, I don't see, a huge change. I think it'll be something to be knowledgeable about, to be aware of, and again, see what you can get there versus what you can get on a direct basis from, especially local carriers like AmeriHealth, because benefits are local. What works here in New Jersey doesn't work in California and vice versa. So to have, strong partners like an AmeriHealth is something that's invaluable. So short term, don't really think it's going to be dramatic, but it'll be interesting to see how it's delivered, what's delivered, and what are the advantages to working with an exchange.
Yeah. Kevin, for a large health system like Atlantic, do you have any concerns about the state-based exchange?
No, I think I think the ACA was we picked up about 360,000 insured lives. A lot of that was through Medicaid expansion. Medicaid expansion in 2014 was about worth at $50 million of previously uninsured. So helped us certainly keep lower rate increases to commercial carriers. So I think it's good that we have that in place, not knowing whether what's going to happen with the federal with Trump's position on some of the ACA. So I think having that backup plan is a good thing, because I do think the subsidies help move a lot of people who were previously uninsured to insured.
So there have been a number of steps taken on the state level to ensure a sustainable individual health insurance market in New Jersey. Has there been a similar approach in the small employer health market?
So as I said earlier, no, and I hope that the state takes the initiative to move in the same direction that they've done in stabilizing the individual marketplace to the small group marketplace. As I said, it's been one of the most robust areas as it relates to employers in the state, and not having the ability to be able to continue to offer affordable coverage to their employees obviously is going to be front of mind for those employers. And we hope from AmeriHealth's behalf, and I think for the state, it's important that we take a look at that. We minimize the ability for companies to come in here and disrupt that and really undermine the work that's been done to try to have a stable, affordable market for small employers in the state.
What should small business owners consider when they're shopping for health insurance for their employees? What advice would you give them?
The big thing, what are your goals and objectives? The one thing that I don't see happening a lot is an honest conversation. Everybody usually comes at it from, let me look at your benefits, I can save you money. Well, okay, maybe, but if I propose a program for you with a $6,000 deductible, is that going to be affordable for a lot of your employees? Probably not. So again, it's that value premium conversation that needs to take place from a strategic perspective. What we talk about at the employer level is, what's your 3-year plan? What's your 5-year plan? What's the line item in your budget attributable to benefits overall? Where are you today and where are you trying to get to? How can we help you get there? It's not only the premium component, again, even based on group size. If you're a larger employer, data and getting a healthier population is extremely important. Very different if you're a 10-life group. If you're a 10-life group, getting access to data, making your population healthier and being able to track that and have the quantitative metrics to really manage it and deliver on that, very, very different conversation. But again, the data is so important. But again, for an employer, it's where are you today, where do you want to get to, and how can we help you get there over 3 to 5 years?
Oh, I would echo Ryan's sentiment as it relates to people are only focused on the rate sometimes, and you don't buyer beware. You got to understand what you're buying. Some of these policies do have high out-of-pocket expense where some individuals that don't necessarily aren't necessarily large utilizers for healthcare don't see any coverage at all because their policies don't really kick in until there's a substantial out-of-pocket cost. We've seen a growth in HSAs, and I'm sure Kevin will agree that that's been a challenge for some of our provider partners with bad debt. That plays into it because people have these high out-of-pocket expenses, and that becomes top of mind for our provider partners. So from our standpoint, small employers should really look at the details, understand what they're buying, understand that rate's not the only thing that's going to drive that decision. And while we understand this is probably their second top line item when they look at their total budget, it's important for them to understand what they're purchasing and how that will impact their employees. Because at the end of the day, the employer's offering that coverage to their employees as a benefit to them. So they need to really understand what they're buying and what their goals are in offering those products, those products.
Yeah, I would just add, I think to, Brian's point, small group is, predominantly community rated, so, there's not a whole lot you can do about the premium, but I think, as employers go from 50 to 100, I think a lot of healthcare systems are making significant investment in delivering value propositions. Certainly our challenge is, as we go forward, understanding transparency, right? What those costs are, because members do have higher and higher deductibles, and we do have a underinsured problem with that, and certainly collection ratios are, the bigger the bill, we still have the same collection ratios, but instead of collecting on a $200 bill, we're now collecting on a $5,000 bill, and that certainly is a challenge. But I think health systems in general are making the investments into value, and I think you're starting to see some of those results through ACOs and other value-based payment models. That I think as employers become more and more educated, because I think employers, just following national trends, are paying much more attention to centers of excellence, value-based models. I think that that's an investment in the future that will drive down the total cost of care.
Right. So this next topic applies to all three of you on fee-for-service and value-based system. What impact is the transition from fee-for-service to value-based system having on the industry in terms of cost savings, and how is that transition going? Is it gradual? Where would you place it?
So just 2 seconds on value-based, right? So historically, fee-for-service, when a provider provided a service to a patient, if you went to your primary care office and you got an office visit, you got a Holter monitor, et cetera, traditionally you'd bill for every one of those services and you get paid. That's fee-for-service. Value-based payment starts from anywhere from, we may negotiate a 3% adjustment with AmeriHealth. Historically, we got that 3% on the fee-for-service. Now you're starting to see, we'll give you 2%, but we'll put another 1.5 into a bonus program where if you hit certain quality metrics, we'll give that to you. So that is a first step in value-based, all the way to when we're talking about, we assume the risk models, where we basically work with the carrier and we set a budget of a certain dollar amount for a pool of patients. And if if costs go over, we eat those costs. If costs go under, we keep that profit. So, going from that one end of the spectrum, when you're moving into these arrangements, you're making, significant investments into what we call our value proposition, right? How are we keeping patients out of the hospitals? How are we engaging with the carriers to get patients into wellness initiatives, those types of things, to drive down the total cost of care. So where are we, I think, today? We're still predominantly on a fee-for-service model. We do have some pay-for-performance in most of our contracts. We moved into risk in a couple of the Medicare pilots this year, and we've done actually very well with that. We are in our first commercial risk contract this year, and it's really the engagement when you're talking about the total cost of care completely changed the whole discussion within a hospital system, right? So now we are, when a patient gets discharged, we're making sure that we're in contact with the insurance carrier, we're reaching out to the patient's family. It's more about, really focusing on the wellness and, coordinating, when that patient got discharged, historically the carriers took over, a lot of the initiatives. Now we're more engaged in those pieces. So, we think at the end of the day, as transparency becomes a bigger driver of healthcare, especially with the high deductible plans, those with the best value proposition are going to be the ones. So I think we're still at the early stages of it. But I think over the next 3 to 5 years, you're going to see significant changes in the way healthcare is paid for in New Jersey.
Yeah, I agree with Kevin. I think currently we're at the front end of this whole thing. I mean, while it's been around, a number of the pilots that have been piloted through the federal government to, as Kevin mentioned, in Medicare to enable folks to be more focused on value than the fee that they're charging for those services has become more and more important. I've been in this business for way longer than I like to admit, and traditionally the fee-for-service environment was pay me for every service that you provide and continue to pay me more over time depending on what my cost of doing business is going to be. And that conversation has changed dramatically over the past few years with the implementation of the ACA, which was an improvement in the dialogue that we're having with our provider partners. We're having more conversations around looking at our members holistically and how do we engage those members more effectively in partnership and sharing with data with our provider partners to enable them to manage those members more effectively. So I think over time what you'll see over the next few years is that we'll start seeing things moving in the right direction of having more of those conversations around how do we move to these contracts. And I think the reality of where we are today is 65% of our network is contracted in some form of a value-based deal where that provider is looking at things a little bit differently with us. What I expect to see happen over time is you'll start seeing more of a shift towards the risk, where providers are taking on more of the risk and more of the responsibility, and we're taking less of that on as an insurance company. And I think that at the end of the day, what's going to end up happening for those members is they'll work closer with the providers, will share information on a more real-time basis to enable them to manage those members more effectively, and at the end of the day, providing the highest quality care that can be delivered to those individuals at the most affordable cost, because everybody's got skin in the game. Everybody's got the information that they need to make educated decisions on where to get a knee surgery, on where to get any elective surgery based on information that's going to be made available to them, on quality scores and evaluating the costs associated with that, because they have so much skin in the game as it relates to how much money they're putting out of pocket for these services.
Mike raised a great point. So, one of the things that's coming out of the value is sharing of claims data. So, we as providers, once that patient left our system, we didn't know if that patient was following up with their mammography or the wellness. By pulling in claims data now provided by the carriers, sharing that with our own medical records, we can identify those gaps in care. And when I say, and so we are now more proactively reaching out, and when a patient pops in the office, because we have the claims data, we can see, what's going on outside of the, outside of our health system, so we can be more engaged with those members. Prior to the ACA, really 5 years ago, health plans weren't sharing data with insurance hospital systems. Now that's a regular course of business, and that alone is a significant game changer. And I think what's got to continue with the value is, alignment between the carriers and the health systems to drive that bottom line.
Yeah, where it really becomes valuable is when we're able to track it and then identify, let's say 3-5 years out, where, just like Kevin and Mike are pointing to, the best care is being delivered. So if you're able to track those metrics and then you're able to point to a system to say, get the care here because the outcomes are better, they're noticeably better, and here's the numbers to back that up, really, really valuable. Claims data, to Kevin's point, it's interesting, right? So more transparency in regards to medical claims, and that conversation is spectacular, to be able to have access to that information. By product, that's not the same. So if you look at some disability carriers, they're getting more and more difficult to deal with in terms of getting access to claims data. So one thing that we're fighting are those carriers that's making it more difficult in those product segments to get claims data because they're just trying to hide it. So it's great in regards to medical, but the overall field isn't going down that same path. So you have to be really, really cognizant of who's trying to be more transparent, who's trying to be less transparent, because you have to fight that, especially the access to the information, especially as employers. that information is yours. It's your employees' information. So having that information, understanding that information is vitally important.
Just one quick point on that. You said that the transition is currently a work in progress. Do you have any predictions on when it will be complete in terms of when value-based will be history? I mean, years, a couple of years, a decade? Any thoughts on that?
I would say from our standpoint, there's a number of partners that are way ahead of others in the state. We're fortunate to have a lot of good partners in the state that we do business with on the provider side of the business, and I think that they're all moving in that direction. Some are ready to take on, Kevin mentioned risk-based deals that they're going into. A lot of other systems aren't there yet. So my expectation is that as Kevin said earlier, you'll see a dramatic increase in that view of contracting from our standpoint of contracting with our provider partners happening really over the next 3 to 5 years. We'll start seeing more of a shift in that direction and more of a focus on how do we work together in managing that member more holistically than really just arguing over a rate.
Yeah, I would say Brian Granulette, our president, is also chair of the American Hospital Association and has been on a national platform pushing, at value. So at Atlantic Health System, we're making some significant investments to be the leader. I think employers, whether it be the Healthcare Transformation Alliance or the Catalyst for Payment Reform, are much smarter, much more engaged than they were 5 years ago. I think the tools to direct patients to more value-based, we see the Walmarts of the world, the Amazons getting into, this space is just really empowering employees to make better decisions, building benefit plans around that. So I think, things are coming together fairly aggressively. As far as 5 years, I think we'll probably be in, hopefully be in more risk contracts going into 21. This was our first big move into it. It's a significant investment on our part, and it's really getting the carriers to line up to make sure both sides, it's a win-win for both sides.
Okay. Accountable care organizations, ACOs, what impact are they having in terms of contributing to lower costs and better care? A relatively new phenomenon, but they're getting more prominent.
Yeah. So that came out of the ACA, right? This CMS Centers of Innovation. So just, in 2018, ACOs across the country saved Medicare $1.8 billion. So it's going in the right direction. We have 4 ACOs. We've done very well. Since 2014, we've saved Medicare more than $100 million. So it's a significant investment. It's a change in the delivery of health care, but we think it's the right direction that's going forward. I think it's also led to a lot of collaboration for the first time. I think that's driving the carriers on the commercial side working in a different way than we did historically with providers. So I think it's got room for improvement, but I think it was a great start.
Yeah, and I would say it's a necessary for our industry to start looking at different ways of doing things. Current model is unsustainable. The old fee-for-service model is not something that was going to be able to continue to operate effectively for the next few years to come. So I think that more and more of these pilots coming down the pike and more of these relationships being started in partnership with our provider partners, that we'll start seeing a shift and change to this pretty dramatically.
And I think from a provider side, I'll just give you 2 quotes that I've used other presentations, but in the 2018 quarterly report came out with at 4 or 5 accountable care organizations, members were more successful in managing chronic disease than members who did not participate in similar care models. At the quarterly report Cigna put out, top-performing accountable care programs, providers demonstrated a quality performance of 11% better than market, with 92% of providers either meeting or exceeding quality benchmarks. So I think that, from our perspective, when the carriers are making, supporting those investments, it's pretty significant. And certainly between the results were there, it's been a good thing for the ACOs.
Yeah, I mean, Kevin said it perfect, right? Collaboration. At the end of the day, that's what it's about. And that's where we're going, is collaboration between systems, between payers, providers, advisors, employers. So even from a political landscape, right? Politics get into the mix when they don't see collaboration and they don't see industry fixing the problem. That's when politics get involved, right? That's always going to be a constant tug of war. That's always going to be there. But if we get it right as an industry in terms of the collaboration, we'll take care of it for our industry. And ACO is right. It's early. We've just begun that path. But again, Kevin points out statistics that support the data, better outcomes, better health care.
Just to get out of this segment on cost, what other steps are being taken to control the cost of health care in addition to what we've already discussed?
Well, I think obviously working with our provider partners and moving in the direction of these types of relationships are important. I'll give an example. Through a relationship, we're a wholly owned subsidiary of Independence Health Group, and through their relationship in another state, had the ability to these contracts to lower the readmission rate within their specific facilities, just to piggyback on Kevin's comments, by over 25%. And so that was in partnership, sharing information, making sure that the incentives are aligned to where we're working together to manage that care more effectively, number one. Number two, I think, we've kind of, for years, we've been talking about, and we've said it here today, the health and wellness, the personal responsibility that individuals have in what they're going to end up costing from a healthcare standpoint. Taking those initiatives, giving people access to information, giving them the ability to understand the cost of what a knee surgery costs, or what it costs to have any elective procedure down the line. It continues to be something that will drive that change in behavior with those members, and really putting some real meaningful incentives / rewards around those people that are engaging effectively. We engage with our population digitally. 75% of our consumers are communicating with us digitally. 65% of our total population that we insure are communicating with us digitally. That's a step in the right direction. We through our parent, went into partnership with Comcast Universal, where we're creating a digital platform for people to be able to engage with us more effectively. And the example that somebody gave me earlier today when we were discussing it was that you could be sitting at home watching your favorite show, and all of a sudden you get a reminder on your TV screen that you didn't take your diabetic medication. So taking it to that level where you're engaging with people more effectively. But where we see it really working, the reason that we've created the company by the name is Quill, is for us to really identify those individuals that really need that constant monitoring to enable us to really work with them a little bit more effectively. So I think all those steps that we're taking as an industry to move in the right direction, be it through our contracting, through our transparency, through the services that we offer our members to engage them more effectively, will hopefully lead to, number one, lower costs, number two, better outcomes, and higher quality of care being delivered to the individuals that we serve.
Even to Michael's point in terms of engagement, millennials want to be engaged in a certain way. Baby boomers, very, very different, right? So when you talk about healthcare and how it's delivered and the level of engagement, you also have to look at your employees and say, okay, what percentage are baby boomers? What percentage are millennials? Because if you have, let's say, one plan, you're going to get very different feedback from your employees regarding that. So you really have to be cognizant of how employees want to be engaged with. Is it digitally? Well, guess what? Millennials love digital engagement. So you would hope over time with the digital engagement that maybe you can drive healthier outcomes because you're touching them at work, at home, on your cell phone. To Michael's point, while they're watching Netflix on their iPad and not on their flat screen TV in the living room. Very, very different.
I would say that, a big game changer is going to be the investment in technology going forward. I just we moved to a new electronic medical record about a year and a half ago. A lot of the major systems across the state are on the same medical record. When a patient gets admitted to our hospital, if they're being treated by, another health system down in South Jersey, we can what they call break the glass and take a look at that medical record. So you just think about, how much duplication is removed from the system, right? If the patient got the MRI down there, we no longer have to do the MRI up here. I think you're looking at investments. I think we're at the cusp with telemedicine. You're going to see a lot more remote monitoring. There's a ton of money and technology flying into the system. I think it's identifying and picking the right partners, but it's going to be more the transition of care of those types of things that I think will have the biggest effect, and that's going to drive the reimbursement models more to risk as we'll be able to keep those patients out of the hospital.
A good example, I mean, to piggyback what Kevin's saying, you look at the opioid epidemic that's facing the country. It was news to me, 20% of the opioids are prescribed by dentists. All right. Yep. So what do we do from a technology perspective so that dentist realizes that there's already an outstanding script being delivered via the medical side that the dentist isn't aware of? So it's where can technology solve those issues that's really, really important.
That ties into your point earlier about collaboration and access.
Right. Yep, definitely.
All right, so let's talk about technology and data. Last week, Google announced that it will collaborate with one of the nation's largest healthcare systems, Ascension, on a project called Nightingale to collect and crunch detailed personal health information of millions of people across 21 states. This raised some eyebrows because it will give a large amount of patient data to third-party technology company without the knowledge of doctors or patients. How significant is this initiative by Google, and where does it fit into the technology data discussion?
So, first of all, there's a number of laws that have been put in place as it relates to our individual members' PHI. So we are not sharing any clinical information on any of our members without their consent, number one. And so it'd be interesting to see how they intend to do that, because the reality of identified information on a specific individual, you can go to jail for releasing that stuff. So from our standpoint, what we've tried to invest in, and similar, is working through our informatics team and looking at trends in our total population to identify opportunities for engagement, be it with our providers or engaging members differently. Anything from how somebody speaks on the phone and being able to get some triggers as it relates to what they're saying to provide better service to individuals and getting them a better understanding of how their program works, to really looking at specific geographic trends within a population to enable us to more effectively manage that specific geographic region. So I think what you're going to see is a shift in using data to enable you to more effectively engage members and really more effectively work with our provider partners in giving them the information to be able to manage our members more effectively. I think that's what you're going to start seeing more and more of. And not only that, you're going to start seeing products being developed around that information that you're being able to obtain within the restrictions, obviously, that the federal government and also the state put in place as relates to being able to move in that direction as effectively as maybe we would want to as an industry, or we were moving prior to the ACA, of providing products really based on those individual specific needs. And that's a little bit harder to do these days based on the restrictions, but I think you'll start seeing a move in that direction at some point.
We have about 10 or 15 minutes left in this discussion, and we'll move on to questions. So let's talk about the elephant in the room, politics. Some of the current Democrat presidential candidates have proposed various versions of Medicare for all. Do you think that Medicare for all or some other form of government health care is a possibility in the current free market-based healthcare system we have in this country?
So the only thing I can guarantee you as it relates to politics and healthcare is that there'll continue to be uncertainty no matter who's in office. We've been dealing in an environment of uncertainty for so long that as an organization that deals with millions of transactions on a daily basis, be it through the phone or through claims, that the changes that come down, be it whoever's in office, will obviously impact the way that we have we can engage with our members. So Medicare for all is a nice buzzword, but if you look at the numbers, it would be something that would be pretty expensive, and I'm not sure how we would be able to pay for that. I think that's more of a soundbite. than the reality. I think that there needs to continue to be work in looking at the system that's currently in place and identifying opportunities, as I mentioned in New Jersey specifically, looking at the small marketplace and giving provider partners the ability to work with us more effectively in the state specifically, because there are some limitations on how much risk a provider can take on for a specific relationship with an insurance partner. So, from my standpoint, I think the one thing that we can count on is going to be continued uncertainty, and depending on who gets in office, we'll figure out which direction we're going to be going in. But we do not feel that Medicare for All is the right way to go because of the expense associated with it.
I think we have a few more minutes left. Let's go back to something. Kevin mentioned telehealth, and I know the health systems are moving pretty aggressively in that area with apps. What, the insurance industry doing anything? Can you guys talk about that in terms of
Sure.
with your patients and customers? Yeah.
Sure. From our standpoint, obviously, we've offered it all along, where we engage in giving people the ability to deal with a primary care provider, be it via video or through the phone. We do see a movement in really the enhancement that we'll see happening over really the next 24 months is a move into the behavioral space where people will be able to engage with therapists more effectively in the privacy of their own home. So we'll start seeing a move in that direction. And you're also going to start seeing a move towards virtual primary care physicians, which is assigning a primary care virtually, and you'll be able to engage with that provider as long as that provider obviously meets all the state regulations. I want to caveat it by that, of being able to provide those services and being able to prescribe for members through this initiative. So I think you're going to see an expansion happen pretty dramatically over the next 3 to 5 years, where more and more services are going to be delivered digitally to individuals based on the technology availability of people being able to do that moving forward. So we've made a substantial investment and commitment to that, and we'll continue to do so moving forward.
Yeah, and it's not only with the carriers, so AmeriHealth is great. It makes it really, really easy. It's embedded. It's there. You see solutions being offered on a direct basis in terms of telemedicine. So you don't only have to get it through your carrier partners. You can also get it on a standalone basis. And you're going to see more and more of that, and you'll be able to really contrast and compare different telemedicine solutions based on level of copays. To Michael's point, behavioral, is that part of it or not with different providers? So that's going to become more and more prevalent over the next 3 years because we've already seen it in the marketplace.
Yeah. I know it's early on, but is the feedback from customers been positive?
Yeah. I say we look at those trends on a monthly basis, and the feedback has been extremely positive for individuals that have had to use it. Again, what you have to look at when you're looking at telehealth is, does that individual get fully satisfied within that telehealth visit, or do they have to go to a provider after that visit? So really looking at that kind of information enables us to make sure that we're doing the things that we need to do to make that more of a meaningful experience for people as we continue to evolve in that direction.
And your feedback has been very good.
Yeah, I'll just say I think we're at the cusp of, if I put telemedicine onto, I think the biggest piece out there right now is the on-demand. My kid's got pink eye. I call up when I get a prescription. I think where you're going to start seeing, and I think we're just at the beginning of it, is a patient gets discharged, you do a video conference at home to make sure that patient's okay. Or, you have chronic patients who's got a remote monitor, you do a video conference call. Those are going to be the changes that you're going to start to see the cost curve bend. And I think we're just at the beginning of beginning to develop that out there.
Okay. Well, listen, this has been great. Thanks so much for your insight. I think we can move on to some questions at this point. So we have some folks with microphones out there, so if you want to raise your hand, we can get started right over here.
Bless you.
I'm Nancy Sargent of Sargent Marketing, and I work with a lot of hospitals and primary care and specialists in their communications. So my question today is specifically about primary care groups, because they're at the forefront of the wellness side. They will be helping on the discharge side. So in 2020, let's say, like right now, the investment of communicating to patients and engaging them, should it be more on the prevention side, or the discharge side, and then seniors obviously have the bulk of the expense. So I have to go back and work on this, today, this week, and actually have a meeting with them today. So where is the best investment in 2020 for primary care?
Let's say in 2020 is really getting people to understand the basics of what they're buying and understanding what their policies are. I think, as Kevin mentioned, there's a lot of time spent in trying to understand how your program works. And with there's more costs associated on your part, you need to be educated in that. So it's our responsibility, not only that we're communicating with people be it through different vehicles, but we're communicating with them effectively at a level that they can understand. So I think we were traditionally, our industry was up here as it relates to the way that we spoke to our members. And as we moved into the consumer marketplace, we really took it down to a level there that we needed to be more in common speak, for lack of a better term, at a level that people could understand how their program really effectively works. So I think today in 2020, primary care is really understanding the program and its basics, and then evolving that into something that can be more meaningful down the line through the information sharing that we've talked about to this panel discussion.
To the patients.
To the patients, correct.
Thank you.
Any other questions? Back there.
Thanks. This question probably would be for Mike. We get beat up. I'm a provider representative for AmeriHealth, and when I go out to provider offices, I always hear, we're the big bad wolf. Insurance companies, nobody likes them, but it's necessary. With all the talk about healthcare costs, what's the role? And we're in the land of pharmaceutical industry in New Jersey. What kind of partnership can we put together, with the pharmaceutical companies to lower the cost of the drugs as well? I don't think nobody's here representing pharmaceutical industry, but what role can they play in lowering the cost of healthcare as well?
Well, obviously, I think that's the thing that you hear the most about these days. Is the cost of pharmaceuticals, and with the new technology that's coming out and the new drugs that are being released, obviously there's a cost associated with that, be it from the Hep C drug that came out, that's $100,000 for curing somebody with that disease, and how expensive that can be. But at the end of the day, is that individual going to be in a better place? And the answer to that is going to be yes, obviously. So I think what we're going to start seeing, and I've seen some companies move in this direction, is directly contracting with manufacturers of drugs and going into the same way that we're going into risk deals with our provider partners and really focused on the value that's being provided, is holding those drug companies accountable to doing the same type of model. So you'll start seeing a move in that direction. Now, you see drug companies or our PBMs, which are the ones that you're starting to hear about most, going into the insurance business. You had the CVS Aetna deal, and then you had the Express Scripts Cigna deal. Express Scripts, I don't know, somebody that happened in the recent days, that now they're getting into it. So you're going to see a dramatic change in the way that we interact both with PBMs and drug companies, and to the extent that some of the drug companies are actually going out and working with insurance companies to put these risk deals in place to enable you to really work with them a little bit differently than you've worked with them in the past. And I think the other thing that's going to be demanded in the same way that consumers are demanding it from us and our provider partners is the transparency of the cost of those drugs. And what is the actual cost of the drug that's being provided to those individuals? Because we've seen an uptick in what we call specialty drugs, which are those really expensive drugs, and that's been one of the biggest drivers that I've seen pretty much over the last 3 years now as it relates to the total cost for our membership.
Any other questions?
Hi, good morning. My name is Pam. I'm a small business owner, and I have a private health insurance plan for myself as a single member LLC. And I had, the question came up about transparency and understanding your coverage in the earlier remarks that you made. So I have two examples by which I can't understand how, as a trying to determine my financial responsibility for two medical situations, I wonder what's incumbent on the providers to be able to give accurate information when they know the costs of procedures. So the one example was late Sunday night, like a couple years ago, I walked into the ER with flu symptoms. I saw a physician assistant, not an MD. They did a nasal flu swab and sent me home. No other test or anything, blood work, scans, blah, blah. And they knew what the cost was. So I get this bill for $931 for just the nasal flu swab. And when I challenged the system about it, I went through my provider. I have a major health insurance provider. They told me that they have a contract with that emergency room for $931. So they know when you walk in the door what it's going to cost, and yet that information is not disclosed. So that's one example where, why am I not informed, knowing that they know what that cost is? Then I escalated it through Horizon, which is my provider, and I get this letter from the medical director that addresses why I was dissatisfied with the quality of care and that my husband didn't get treated what he needed to get treated for. So the letter was completely inappropriate. I don't have a husband. There was not a quality of care issue. It was a transparency, and it was challenging the cost for what is like a routine service that shouldn't be that expensive. And so that's one example. The other example is I had an outpatient procedure at a surgical center, and it's a routine procedure, GI office, regular guy, established in business. And so I called up the office in advance and said, can you tell me what my financial responsibility is? Because it's anesthesiologist, blah, blah, yada, yada. So they're going to me, okay, well, we think it's going to be this much for the anesthesiologist, the doctor, and the facility. So 10 minutes later, I'm going, okay, so that's my cost. The facility then calls me separate from the doctor office, gives me a number 3 times the amount that the woman in the billing office gave me. And then a month later, I'm getting bills that it's over $3,500 at this point, and they quoted me like $900. So I'm in a position where I placed a call in advance. I'm trying to get information around my responsibility. I know what my coverage is. They can call Horizon with the diagnostic codes and get an estimate that's much more close to what reality is. So help me to understand the system and the transparency that you spoke about earlier, because I'm trying to get my head around, what my responsibility is.
Yeah, and I think you're speaking loud and clear to the reason that we've moved in that direction, and some of this transparency is being mandated to an extent. And, from our standpoint, we do provide, I can't speak for any other carrier, I can speak for AmeriHealth, we do provide a cost care estimator that gives you the ability to get a good understanding what potential out-of-pocket costs are based on the benefit package that you have with us. So we've moved in that direction, but I can attest to the fact that we've had instances where, depending on how you ask the question, that you get a different answer. So we're getting to a point where we're refining that process to enable us to give accurate information to our members as it relates to what their true out-of-pocket costs are. And I think we've taken the steps to do that, and it'll continue to improve over time. So hopefully, when you become an AmeriHealth member, you'll have the ability to do that a little bit more effectively.
My premium is going up an extra $80 a month starting January 1st to $1,000 a month.
That's not cheap.
And if I go out of network, I have no coverage at all.
Yep.
No insurance out of network, and a 50% collection.
Yeah.
So I'm looking at other providers.
We're more than welcome to take a look at AmeriHealth.
Actually, I have a question. This is tied into the Medicare for All we discussed a little while ago and government intervention. Last week, Senator Booker introduced legislation along with Bernie Sanders and Kamala Harris that would essentially establish a drug pricing system similar to Canada, based on what you discussed earlier. Are you concerned that if the drug companies themselves or pressure on the drug companies by insurers or health systems don't do something like that may actually...
Yeah, I mean, I think that's what I've been hearing, and I think anybody that watches the news at this point is the cost of drugs and that we need to do something about it. So in the same way that we moved away, and again, I said I've been in this business for way too long, that we've moved away and moved into more of a partnership role with our provider partners, that the same thing needs to happen on the pharmacy PBM side of the business, because the lack of transparency there, we just talked about the challenges this woman had as it relates to understanding health care. If you really dug into the overall drug cost, it's a lot more complicated than that. So, from our standpoint, yeah, I think you need to move in the direction of, I think pharma will make the decision to do that before it's legislated on their behalf. The way we see this plan.
Yeah, even the current administration, this was probably 3 or 4 months ago, right? They went in that direction.
Yeah.
We're going to mandate all this stuff. We're going to change it. Drug pricing is a major issue. And then what happened? They lost that appetite for whatever reason. Maybe they got a phone call from pharma. Who knows? And then all of a sudden, it fell by the wayside. And then what do you have now, based on Anthony's comments? Politicians stepping in because it's perceived that the industry isn't taking care of the problem. So we need to do it because we know best. And we'll mandate it, and we'll legislate it away. So again, getting back to that, identify the problem, fix the problem, and then the politicians will stay out of it. All the time? No. They'll always be on the fringes. They'll always be there. But at least if we're fixing it and we're moving in that direction, they'll go figure out something else to focus on.
Yeah, I think, at our investment in value, I think if we don't fix the cost problem, we're going to see more regulation, and I think, less regulation is better for the delivery of healthcare. So I'm certainly sure that the pharmaceutical companies are feeling that too. I mean, some of the specialty drugs, there's no one out there. We're one of the only hospital systems in the state that provides $2 million. I mean, the costs are incredible, and you're starting to see more of that. So it's an issue that's going to have to be addressed.
Any other questions?
Hi, I'm with NJIT, their New Jersey Innovation Institute, and I wanted to ask about how you're looking to get some. You talked about some challenges and needs to get innovation into what you're doing, and what are some of the mechanisms that you might be looking at to try to interface with either incubators, startup companies, accelerators, perhaps putting out challenges? Johnson & Johnson has a program called J-Labs where, again, they try to get early-stage companies together. Are those some of the kinds of things that you would consider looking at as a way to kind of get a funnel for some other insights, perhaps from people from the tech industry who aren't necessarily, steeped in your insurance areas, to kind of help try to address some of the challenges that you talked about?
Yes, that's a good question. From our standpoint, through our parent, Independence Health Group, we've had the ability through an initiative that's been in partnership with New York University along with Penn, in bringing incubators, startups that are focused in healthcare from all aspects of it, be it from the clinical side of it to the transactional side of it, and bringing them together and having them compete and have access to insurance companies and provider partners of what their technology can do and improve on. So I think that's a great way for us to have the ability to see what's coming down the pike and things that can improve the overall experience, both for our members, make it more affordable for us to be able to provide those services. That's where we've kind of doubled down on as an organization, is supporting those initiatives that bring these people together and give them a platform for them to be able to be it incubate with us, which we've done in a number of instances, or have access to those people that can help them incubate if we're not the right choice for them.
Yeah. So we recently hired a chief innovation officer. That role will be, there's a tremendous amount of startups. I mean, every day I get emails from different startups. So we'll be the person that will kind of funnel those ideas, bring them to the right groups to kind of, flesh out which ones create the best opportunities. So, certainly the direction we're headed as well. Dr. Sylvia Rahm.
Anyone else?
I actually have two questions, so I'll start with just yesterday I saw a commercial from CVS saying that they're now going to start providing people who walk in with a prescription options and the different costs, and Can you share anything on that? That's the first I've heard of that. And is that where we may be going to in the future to try and control pharmaceutical costs?
Well, I mean, CVS is looking to go direct to consumer in a lot of different areas. So you're going to see the CVS model that exists today. It's going to be very, very different 2 years from now. You're going to walk into a CVS and there's going to be doctor's offices. They're going to be delivering care at that CVS. So you're going to see it not only in regards to prescriptions, you're going to see it regarding the entire delivery of healthcare at that location. I mean, they're changing their footprints, from a real estate perspective to be able to accommodate those services.
And my second question regarding high deductible plans. So over the years, they've become so popular, and I'm just wondering, are they working on, in the eyes of Michael? Are they working for the insurer? How are they working for the hospital? You briefly touched on, debt. So they become more and more popular, but are they a good thing, and should they stay?
So I don't think it's an affordability question, right? So, a high deductible puts the insurance plan at a price point that maybe makes it more affordable, so that's a positive. I go back to, from a provider's perspective, we still have the same collection rate, but so if our bad debt is X percent, it's X percent on a claim that used to be worth about $500, now it's worth about $1,500. So it's certainly driving up bad debt. Medical claims are the number one reason for personal bankruptcy in New Jersey. I think these high deductible plans feed into that. I will also say, and I think it's a sign of the economy, that going into 19, we saw a leveling off, even slight decline on employers offering the high deductible plans as they're competing more and more for talent. The benefit plans are being enhanced. So it has leveled off, but certainly, you have some people out there that, have some really expensive bills.
You have to have the conversation regarding what's the healthcare spend, right? Those plans have gained popularity just because of the premium price point that they're delivered at. But we look at it from a total spend perspective, very, very different conversation in terms of most people with those high deductible plans stay away from services because they can't afford to get services on those types of programs. So again, they're hitting the price point that people are looking at, but if you're expanding the conversation to what the total spend is in terms of deductibles, co-pays, when am I actually going to get services delivered via that policy, it's a very, very different dynamic.
And Brian brings a great point. I mean, the problem is it's also people skipping care, and that's been pretty well documented with some of these plans that they can't afford it, they avoid it just because of their responsibility.
Yeah, and I think obviously we've seen a tremendous growth at AmeriHealth specifically in those types of programs, and I think what employers have done to circumvent some of the things that have been mentioned by the other panelists have been fronting some of that front-end cost to them because they're able to provide it at a lower expense, but they're also able to provide some portion of that front-end deductible to enable them to be able to have some first-dollar benefits in doing so. So I think that it's not going away because the affordability issue continues to be out there, but you'll continue to see creative ways for people to be incented to practice a little bit more effectively than they've done historically. So I think you'll continue to see employers looking for different ways to incent people by giving them dollars on the front end of those programs.
Right here.
Hi, Gail Seibert with Faring Pharmaceuticals, based here in New Jersey in Parsippany. My question is for Brian. I think it was Kevin who said that with the economy being the way it is, some of the high deductible health plans maybe aren't as popular right now as employers compete for good employees. We're the number one manufacturer of infertility products in the world, and what we have seen across the country, particularly with high-tech companies, is that as they compete for particularly young women who are starting their careers, they're starting to provide more infertility treatment services, particularly egg banking, for those women that want to start their families a little later in life. Are you seeing, Brian, your customers starting to ask for those services or those benefits for their employees?
Yeah, definitely. Infertility is always part of the conversation, especially if you're dealing with an employer where they're heavily, females as opposed to males. That's going to come up. It's definitely going to be part of the conversation. And it all starts with what's being demanded by the population that you're dealing with. So whether it's infertility, whether it's any product, you drop it in there. It has to be delivered because it's what's important to your population. But to your question specifically, without a doubt, it's more and more popular. It's definitely part of the conversation on an ongoing basis. And that's going to continue. That's not going to decrease, definitely. So again, that's a different conversation altogether, right? Because now you're dealing with a larger employer, self-funded. That claim conversation is extremely, extremely important. So is it going to be part of the conversation? Yeah. And then depending upon the company that you're dealing with, maybe it's positive, maybe it's negative. Who knows? Because they're looking at it from a claim cost perspective, not necessarily I just have to give my employees anything and everything that they want. So it needs to be discussed. It needs to be part of the conversation. And yeah, anything in regards to, self-insuring. Self-insuring is great because you have the data. And that's the most, basic model that needs to be always spoken about. Because anything that gives you data, we spoke about it a few times today, is great because that'll give you directionally where you want to go, where you can get to, because you know where you're starting from. But to answer your question, yeah, it's even more so on self-funded programs because you're looking at the underlying claim spend from the employer perspective.
I just want to make reference to one point, though, infertility specifically. It's something that in New Jersey wasn't a benefit that was readily available, so the legislature made a decision to put a mandate in place to make it more accessible to people. Those are necessarily available. And again, just to be clear, I oversee a TPA for one of our subsidiaries, and through that we insure 500,000 people on self-funded programs. They're large employers; they make those decisions. They want the information, as Brian said. But for these small employers, what's happening is, to Brian's point earlier, is that they don't know what they're buying. They don't know that in most cases these companies that don't participate in the regulated markets are carving these things out. And those protections that were put in place to provide those types of services to these individuals aren't being made available to them through these self-funded small group policies. So, exactly. And the cost of that, as you know, is pretty substantial. So, buyer beware, as we spoke earlier, for those small employers making those decisions.
And that gets to the employer. What's the underlying driver at that employer for that owner? What are they trying to accomplish? Is it just to hit a price point and they're going to carve things like that out? Or is it, I want to take care of my employees and really, really do good by them? Two very different mindsets, and they both exist on a daily basis out there based on the employer.
I have a question about preventative health campaigns that both health systems and insurers are involved in, everything from the flu vaccine, pneumonia, shingles. Have you been increasing your budgets towards those preventative things in the last couple of years? Are they working, getting a return on investment, or more and more patients responding to those type of preventative promotional campaigns?
So obviously in the regulated markets, yeah, that's part of their basic coverage where they have to comply with that and make those services available at a low out-of-pocket expense. What we've tried to do is incent people, because in spite of that, there's still people that don't go in and get the preventative services. So what we've tried to do is design programs to provide incentives for individuals to go and get their BMI, get their colorectal cancer examinations, go in and get their annual physicals, incent them to go get their flu shots, because obviously doing those things is going to be more beneficial to them than not doing those things. So providing those incentives and engaging with them effectively to remind them that they should be doing those things are important and front of mind for us and how we do operate with our membership today. And yeah, we're investing substantial dollars in making sure that people are aware of it, that's available to them, and encouraging them to do so.
Yeah, we even talk a lot of our clients about the healthcare spend. So whoever's sick today, that's easy. Identifying who's going to be sick 3 years from now, 4 years from now, that's the really valuable part of the process. If you can identify who's not going to be healthy in 3 years and identify programs today that'll prevent them from becoming sick 3 years from now, that's really, really, that's heavy. That's really important. And that'll, bend that cost curve down. Very hard to do. Not easy to do. But if you're constantly looking at, the biometric screenings, having everything done at least on an annual basis to prevent people from becoming sick and, quite honestly, prevent people from themselves in a lot of cases. Even at our company, you have to, at a minimum, go for your biometric screenings, your annual physicals, and you get $1,000 off your medical premium, and your spouse gets $1,000 off there, provided both go through that at least on an annual basis. So, to Michael's point about building in incentives, structuring a program, building a strategy around it to really force outcomes and delivering, lower healthcare costs overall.
And just to be back, as it relates to information, is one of the focuses when we're spending money as it relates to informatics and having that data available to us is do that predictive modeling to enable people to be able to identify things earlier on in the process and engage them more effectively earlier on. So I think that's going to be a continued focus, at least on our part, and our industry for that matter, in giving people the ability to understand things much earlier in the process than they've done historically.
Any other questions? Right there.
Jason Delapenna with Brown & Brown Insurance. Thank you all for your time today. Question about provider access. One of the things that you hear about with Medicare for All and just, hopefully more and more people continue to get coverage. Are there enough providers? Are there enough providers, healthcare providers in the pipeline? And if not, are there any solutions?
Yeah, I just know, certainly, it seems like there's going to be a primary care shortage in the future. So, I think working with APNs and others to expand that base. So, it's sort of a changing delivery model, but it certainly is something that's concerning in our planning department at the hospital is a future shortage of physicians.
And there's a shortage. The shortage obviously is already planned for based on the expansion and the growth within the population. And I think from our standpoint, you're going to start seeing a movement into that virtual world of people engaging with the providers virtually because of the shortage that happens in primary care. You have a lot less physicians going into primary care practice than you do going into other specialties based on the finances associated with that. Because it's challenging for a primary care physician to be able to operate in a market like New York, New Jersey, or Pennsylvania for that matter, because of the costs associated with operating in those markets and the reimbursement levels of those providers. Obviously, they're at the low end of the spectrum when you start looking at, do I become a brain surgeon or do I become a primary care provider? So we would expect that you're going to see a shift, to Kevin's point, to nurse practitioners, LPNs, and an expansion through those vehicles, as Brian mentioned earlier, to the CVSs of the world, which is you're going to start seeing more access made available to different sources.
Anyone else? We have a few more minutes. Okay, so, I'm sorry, right here. Thank you.
So this probably goes mostly to Kevin. When you look at value-based care, is it integrated to include prescription drugs? And does it look beyond a year when you're doing your measurements? So, for instance, if someone needed a preventive surgery that would be expensive, but you could push them off to a lifetime of prescription drugs, how does that get captured in the value-based measurements?
I would say we're not there at that level. I think we're looking at risk scores. We're identifying, patients with, chronic diseases, those types of things. We're trying to work with the plans on, understanding their wellness initiatives, those types of things. I think it's more better coordination with the patients now. We're working closely on the readmissions, those types of things. Certainly, we are in our risk deal. We are responsible for that pharmacy trend, but I think that the curveball of some of the stuff is some of these specialty drugs that are coming out of the pipeline and managing those pieces. But if there's no putting off surgery, if a patient needs surgery, you're going to do surgery, and I don't think it's gotten to that level. As far as tying those pieces, it's managing the patient today, making sure that patient's getting the best coordination, make sure that they're getting out of the hospital and staying well outside of the hospital.
Right there, one more. Last question.
Bob Trotta, Medical Claims Billing. Just a quick question. Kevin, what services would you want Michael to pay for that they're not paying for today? And again, this gets to the point of
Yeah,
the primary care issue that there's
you know
all
what?
kinds of other types of providers.
That's a good question. I think the reality is payment policies always don't keep up with technology. And I'll give you an example. As we're experimenting in, remote monitoring, and I don't know if AmeriHealth covers this. I'm just using this as an example. As we're putting more of these policies, testing out these new models, oftentimes there is no reimbursement for it. Right now the plans are paying us care coordination fees because with this new model, we've had to hire social workers, provide sometimes transportation to drive down the total cost of care. I think some of those investments need to continue and even grow. I think as those grow, we're taking on more of the role of the carrier. We need to figure out where that reimbursement crosses over, and I think that's where you start going from fee-for-service to risk, because we're going to do the best we can to keep those patients out there. But I think there's a little bit of a challenge there. I think that's where providers and payers need to work together and, quite frankly, build a better system of trust, because I think we're both under the same pressure from employers and from the government that we have a problem to fix. So I think it's got to be more of a collaboration going forward to really bend this cost curve, because I could say I'm sure the three of us would all agree the last thing we want is more regulation. So I think it's figuring out how do you work out these new pieces on payment going forward.
All right. Well, thank you for your questions. Now we'll wrap up. We'll give each panelist a few minutes to give us some closing statements. Now we'll start with you, Michael.
Thank you again for having me here today. From our standpoint, we continue to be committed to the New Jersey marketplace. It's our only focus, and we continue to look forward to working with partners like Atlantic Health in the future and really changing the footprint of what's happening in healthcare in the state.
Thank you for having me. I have to say, I think it's a very exciting time in healthcare. I think there's tremendous opportunity. I think you're going to see some significant changes over the next couple of years, the delivery and the financing. And, I think my recommendation to any employer is to really look at the products, because I think, as plans are putting in the high-performance networks and those types of things, they're recognizing the value and driving your members there, and I do think it does have a total cost of care. So if I was an employer, that's one of the things that I would be looking at going into the future.
Thanks for the opportunity to talk to you all today. Appreciate it. I'll leave you with just collaboration between all the stakeholders. So whether it's the three of us, whether it's an employer working with your broker, just be transparent, have the conversations, collaborate, and figure out best practices. So this way government will stay out of it, and we'll fix it. They won't. So thank you again.
Well, thanks to the panelists. Terrific job. Thank you. Really appreciate it. And thanks for coming out this morning, spending some time with us. I'll ask Jeff to come up with some closing comments. Thank you.
Thank you, Anthony, and thank you, Brian Bodner, Kevin Joyce, and Michael Munoz. As always, we'll have full coverage of this event later today on NJBIZ.com, and expanded coverage in our next print edition, which is December 2nd. It's not the 25th. We don't have anything during the week of Thanksgiving, so look for that. We'll also post a video of the whole thing on our YouTube channel probably in about a week. And thanks to Kane AV for handling the video and the sound. If you want more information about Kane and what they can do, stop by the registration desk. And if you can, please join us at our next event, which is really a special one, a symposium on women in business, featuring a keynote by Janet Dutch, who is also our cover subject this week. She's the president of the New York Guardians. It's a New Jersey-based XFL franchise. They're going to start playing in February, so you can read about her now and come hear what she has to say. That's December 17th here at the DoubleTree. I hope to see you there. Thanks for coming, everyone.